Welcome to 542 Module 2 lecture on cardiovascular assessment and diagnosis. The readings for this week's module cover a review of the comprehensive assessment of a geriatric patient and the assessment and diagnosis aspects of cardiovascular complaints in the primary care setting. Next week, we will proceed with the management of cardiovascular conditions. Clearly, cardiovascular disease is a major health concern in the United States. In the primary care setting, our job is to perform the appropriate assessment to identify the presence of cardiovascular disease in our patients. Although statistics regarding mortality related to cardiovascular disease are improving, it is still a significant contributor to morbidity. For those patients with cardiovascular disease, the goal is not only avoidance of any acute coronary incidents or death, but also maintenance of as high a quality of life as possible. Cardiovascular disease affects millions of Americans, and the costs associated with cardiovascular disease in the United States are estimated to be in the billions of dollars. These are cardiovascular conditions frequently encountered in the primary care setting. We will discuss specific assessment and diagnosis aspects of each of these. These are cardiovascular conditions that require emergent treatment and that you will want to be able to recognize. The textbook acute myocardial infarction patient is a male, middle-aged or older, with complaints of heaviness or pressure in the chest. Excuse me. The pain may radiate into the jaw or left arm. They may also have numbness or tingling in the left arm. Diaphoresis is common among patients suffering an acute MI. Females more often have atypical symptoms when experiencing an MI. Dyspnea, fatigue, or GI symptoms may be their chief complaint. A dissecting abdominal aortic aneurysm typically occurs in elderly white males who present with pulsating abdominal or low back pain. Severe chest and back pain occurs with impending rupture. Hypertension and smoking are risk factors for abdominal aortic aneurysms. The textbook bacterial endocarditis presentation is fever, chills, and malaise, along with abrupt onset congestive heart failure or new murmur. Subungual hemorrhages, petechiae on the palate, painful purple nodes on fingers or feet, and tender red spots on the palms of soles of the feet may also be present. These are common chief complaints presented for cardiovascular conditions. We'll review each of these in a bit more detail. When a patient presents with chest pain, determining whether or not it is of cardiac origin is priority. The most common non-cardiac cause of chest pain is gastroesophageal reflux disease, but chest pain can also be caused by anxiety, pulmonary embolism, costochondritis, pulmonary hypertension, or gallbladder disease. This is a list of non-cardiac related causes of syncope or near syncope. In addition, orthostatic hypotension and conduction abnormalities or arrhythmias are potential non-ischemic causes of syncope. Dyspnea. Pneumothorax, pneumonia, anemia or hemorrhage, congestive heart failure, asthma, pulmonary embolism, COPD, and panic or anxiety are potential causes of dyspnea other than ischemic heart disease. Although dyspnea may be the only complaint in some ischemic heart disease patients, it's very important to distinguish, as indicated on the slide, between pulmonary versus cardiac etiology of dyspnea. With pulmonary, the increased dyspnea with breathing effort, shallow, rapid respirations typically. The posture does not impact their dyspnea much, and recovery after exertion is rapid. With the cardiac etiology, the dyspnea is typically increased with recumbency when they lay down, the shallow respirations, and it takes longer to recover after exertion. This outlines the general cardiovascular exam, some findings. Following a thorough history of present illness, past medical history, family history, and social history, a thorough physical examination will assist in determining the likelihood of a patient's complaints being of cardiovascular or other origin. These are general examination observations listed that can be made to help with determining initial differential diagnosis. Auscultation of heart sounds is a skill that requires repetition, repetition, and repetition. I will post a link to audio files for you to practice, practice, practice. I would encourage you to do so. And as you go through your clinical, the more normal heart sounds you hear, just the more people that you listen to their chest, then you'll be more apt to pick up on an abnormality. Complications from persistent hypertension include renal failure, stroke, myocardial infarction, left ventricular hypertrophy, peripheral vascular disease, retinopathy, heart failure, and aneurysms. Problem with hypertension is that patients are typically asymptomatic, so it's difficult to get patients to seek treatment, and also they don't feel better necessarily when it's under control, so that's difficult to encourage compliance with medications. Um, you can't have a patient diagnosed with hypertension based on one blood pressure reading. You need an elevated blood pressure documented on at least 3 separate occasions, at least 1 week apart. Smoking, diabetes, alcohol use, and obesity are all risk factors. African Americans are at increased risk for hypertension. Hypertension is classified as either essential or secondary. Essential hypertension, for which there is no known direct cause, is the most common, accounting for 90 to 95% of all hypertension. Secondary hypertension is caused by disease processes such as kidney disease, adrenal tumor, or pheochromocytoma. The assessment and diagnosis of hypertension is pretty straightforward. Unfortunately, the management of hypertension, which we'll cover in our next module, can be very difficult. Hyperlipidemia is also classified as either primary or secondary. Primary hyperlipidemia refers to a genetic disorder that creates the overproduction or inability to clear triglycerides or LDL, or the underproduction of or overclearance of HDL cholesterol. The majority of hyperlipidemia cases are secondary and occur as a result of lifestyle and diet. Some medications can influence lipid levels. Diabetes, obesity, and hypothyroidism contribute to hyperlipidemia. As with hypertension, the assessment and diagnosis of hyperlipidemia is quite straightforward, but there is some controversy regarding the treatment guidelines that we'll explore in next week's module. Unfortunately, like hypertension, hyperlipidemia patients are also typically asymptomatic. It's typically diagnosed on routine lab work, or cardiovascular event could be the first indication that they're hyperlipidemic. Heart failure. These are the symptoms most heart failure patients will present with as their chief complaint, either shortness of breath, dyspnea, orthopnea, edema, or weight gain of several pounds in 1 week. These same symptoms may be indicative of many other disease processes such as COPD, so appropriate assessment is important to correctly diagnose heart failure. These are findings which you may identify on physical exam that are suggestive of heart failure. The weight gain I previously mentioned, you can have tachycardia, an S3 or S4 heart sound, neck vein distension, rales in the lower lobes, and a lower O2 saturation. Classification of heart failure is based on risks, cardiac structural changes, symptoms, and functional abilities. There are several examples of heart failure classifications, but here's an example of the Cardiologists and American Heart Association classification symptom, which goes stage A through stage D, A being minimal compared to D is more severe. Diagnostic tests for heart failure are listed here. An echo can be utilized to confirm a suspected case of heart failure and to determine if the left ventricular ejection fraction is preserved or not. EKG changes can indicate structural changes related to heart failure. The severity of valvular disease can be determined via angiography. A plain X-ray may show enlarged cardiac silhouette, increased pulmonary vascularities, interstitial edema, or pulmonary edema in a heart failure patient. Treatment options are varied depending upon the type and severity of heart failure. We will explore treatment guidelines in our next module. These include, in addition to the diagnostic tests, and the labs that you'll typically draw for a heart failure patient are listed here as well. With deep vein thrombosis, also known as DVT, the chief complaint is typically lower extremity pain and swelling of gradual onset. Diagnostics for DVT include ultrasound, D-dimer level, or venography. Superficial thrombophlebitis is inflammation of a superficial vein, typically due to trauma. Patient will usually present with acute onset of localized redness, swelling, and tenderness. An indurated cord-like vein, positive for warmth, tenderness, and surrounding erythema, will be noted on exam. There should not be edema or swelling of the entire limb with superficial thrombophlebitis, as there is with DVT. We will review treatment of these conditions in next week's module. Risk factors, as listed on this slide for deep vein thrombosis. Frequently, patients will present after having been on a long, overseas plane ride or a long road trip. If they've been ill and on bed rest for some reason, they can have inherited coagulation disorders that can contribute to onset of DVT. Also, oral contraceptives, pregnancy, long bone fractures, and malignancies are risk factors for DVT. Peripheral vascular disease and peripheral arterial disease. Hypertension, smoking, diabetes, and hyperlipidemia are risk factors. Medium to large arteries in the lower extremities are narrowed over time with decreased blood flow, ultimately resulting in permanent ischemic damage. Patient will typically present with complaints of pain with ambulation, intermittent claudication, quickly relieved with rest initially, but may progress to pain even at rest. On exam, you may note shiny, hairless, hyperpigmented skin on the lower extremities, cooler to touch, and decreased or absent pulses. Diagnostics include an ABI, a ratio of ankle to arm blood pressure, Doppler, and angiogram. Patients may be asymptomatic with arrhythmias or valvular disease. Patients also may report palpitations, fatigue, chest pain, or dyspnea with valvular disease or arrhythmias. Diagnostics for arrhythmias include EKG, Holter monitor, echo, electrolyte panel. Heart rate, duration of the arrhythmia, and presence and severity of underlying heart disease determine the patient's ability to tolerate an arrhythmia. Listed here are the various etiologies that contribute to development of arrhythmias. They include pre-existing heart disease, age-related changes, systemic disease, electrolyte disturbance, and drugs. Valvular disease. This can be come about as a response to age-related thickening, dilation, or calcification of valves. Again, systemic disease, history of myocardial infarction, radiation therapy, and certain drugs, medications. On physical exam, murmurs associated with valvular disease may be detected. However, murmurs can be caused by anemia, thyroid disease, or hypertension as well. Murmurs will vary depending upon the valve involved, so again, you'll need to practice your heart sound auscultation skills and review the various sounds created by abnormalities in particular heart valves. Diagnostics for valvular disease include EKG, chest x-ray, echo, Doppler, and cardiac catheterization. Again, depending upon the valve involved and whether or not the onset is acute, the various diagnostics will demonstrate different findings with which you will want to be familiar. Review the sections in our text regarding the diagnostics for specific valves. Although chest pain is the most common presentation of ischemic heart disease, not all patients will complain of chest pain. Some studies have revealed that the majority of women do not present in typical fashion and have primary complaints of nausea. Remember, a thorough history is vital when assessing for ischemic heart disease. Anginal pain typically lasts for minutes, is usually substernal in location, with radiation to neck, arms, or jaw. It is usually precipitated by exertion or stress. Risk factors for ischemic heart disease include smoking, hyperlipidemia, diabetes, obesity, metabolic syndrome, sedentary lifestyle, and a family history of ischemic heart disease or peripheral arterial disease. In addition to a thorough history of present illness and family history in the exam, the following diagnostics are utilized to determine if chest pain is an indicator of ischemic heart disease. EKG, cardiac markers. Even without changes on EKG or cardiac markers, patient may still be suffering from ischemic heart disease if risk factors exist. characteristics of chest pain suggest an exam supports ischemia. So do not totally depend on the diagnostics. Once you have determined that the chest pain is of cardiac origin and is suspected to be ischemic in nature, then you will need to determine if the angina is stable or unstable. If the angina meets the criteria for unstable angina, then you'll need to determine the patient's risk for acute MI or death. These are the American College of Cardiology / American Heart Association's criteria for categorizing unstable angina. According to their guidelines, high and intermediate risk unstable angina patients should be transported immediately to an emergency department for evaluation. Low risk UA patients can be evaluated in an outpatient setting. With any new onset unstable angina patients, consultation with a cardiologist for further workup, stress tests, etc. would be warranted. Cardiovascular assessment and diagnosis is not something that can be thoroughly covered in one module. The hope is that by reviewing these complex topics each semester through readings, lectures, and case study discussions, your understanding will deepen. I strongly encourage you to explore the resources listed here to further your understanding. As you continue to see more patients in clinical, then you will be able to apply some of the information we've discussed, and that will also serve to enhance your understanding. Next week, we'll delve into the management of cardiovascular disorders. These same resources contain a plethora of information on both the assessment, diagnosis, and management aspects for cardiovascular disease.